Thanks very much. So I'm going to give a brief update on the status of LADB implementation and enrollment of people using opioids into the cohort study. So this is the module 2 that Kim referred to. So just to remind people, the study designs an observational cohort among people who use opioids with a follow-up at 24 and 48 weeks. Our primary analyses, slides. Our primary analyses focus on measuring 3 co-primary outcomes at week 48 among those initiating LADB. So the first is treatment satisfaction, which is measured through the treatment satisfaction questionnaire for medication. The second is retention into treatment, which is defined as the proportion of participants who receive LADB at week 48. And the third is the use of non-medical opioids. So that's defined as the number of days opioids were used in the past 28 days. So we will also explore what comparative analyses can be done by firstly comparing changes in outcomes from baseline to end-line among LADB initiators, and secondly, conducting comparative analyses with participants who are continuing or initiating other available opioid substitution therapy. So this slide summarizes the treatment pathways through which participants are recruited across the 8 countries. So in total, we're aiming to recruit 760 people initiating LADB. In Egypt, Nigeria, South Africa, they will only recruit participants who are currently not on treatment. The rest of the countries will recruit mixed samples of people who are treatment naive or transitioning from methadone or sublingual buprenorphine. In Ukraine, some participants may have had past experiences of LADB, as well as we've already heard. So there's a great deal of variation in treatment experience across our sample. And we're collecting detailed data on induction of LADB from the treatment pathways and paying particular attention to those who are transferring from high-dose methadone. So those who are eligible for LADB but choose not to start LADB and remain on or start another form of treatment will also be invited to enroll into the comparison group. In some countries, comparison groups will also be drawn from those already on treatment. But the aim is to recruit equivalent numbers into the comparison group. So after very lengthy work obtaining ethics and import approvals, we're due to start enrollment imminently. So if you've heard from Anna and from Kim, Kyrgyzstan have already started recruiting their cohort of 100, with 3 people enrolled already. South Africa has just received LADB and last week started the enrollment process, beginning with a pre-assessment screening of 5 people with a view to starting sublingual buprenorphine this week, and if stable and appropriate, onto the first injection of LADB over the next few weeks. LADB is also arriving at the end of October into Ukraine, so they'll shortly be starting enrollment there. And Vietnam, Tanzania, and Egypt are due to start in December. India is still waiting for ethics approval, but scheduled to start in January, all being well. And we've just heard that we've had the green light from the Ministry of Health to implement LADB in Nigeria, alongside their emerging program of methadone. And that's thanks to very careful and patient negotiation from Dr. Michael Kingsley, Dr. Bashuran from NSCP, the team at SFH, Annie Eddy from DAFO, and also the PSI leadership in UNITAID and WHO. But the delayed start to provision means that we're going to have to engage in more rapid recruitment of our participants in order to allow for the 48-week follow-up within the study timeframe. And with a view to getting enrollment started quickly, we've provided training in the clinical procedures that's overseen by Dr. Nico Clark. We're setting up monthly clinical meetings to provide clinical support on an ongoing basis and encourage cross-country learning across the teams. And this mentoring support will occur alongside a study safety group that's monitoring adverse events. One of the concerns about the study has been the lack of a certainty about ongoing provision of LADB at the end of the study period. So we've had lengthy discussions across the consortia and with the Community Advisory Board about how to manage existing supplies. And in the short term, so for example, in the case of that people choose during the course of the study to stop using LADB and don't return to treatment, we have agreed that we'll allow some leeway for people to return to treatment for up to 3 to 4 months. But should they not return, then these doses will be reallocated to people wanting to start, and they'll be enrolled in the study, where there's a sufficient time for our 12-month follow-up. But if that's not possible, then excess LADB will use to extend the existing time of existing cohort participants. And then I think you've heard about the longer-term efforts to ensure supply, which includes contributing evidence to the WHO OEMT guidelines, discussions for the inclusions of LADB in the Global Fund Grant Cycle 8, and then also all the work at the country level to ensure LADB is registered. Okay, I'm just wrapping up. So then, in advance of implementation, countries have been focused on raising awareness of LADB among communities using materials prepared by the Community Advisory Board, as well as conducting some of the qualitative work that you've heard before. So thanks very much, and happy to answer questions in the break.